Welcome to our comprehensive review of ventricular septal defect in pediatrics. I am Dr. Abdelaziz Yousef from Pediatric Case Review, and today we will explore this common congenital heart defect that affects approximately 3 to 4 children per 1,000 live births. This lecture is designed for pediatric residents and fellows, providing a structured approach to understanding, diagnosing, and managing VSDs. Throughout this presentation, we'll examine key aspects through case-based scenarios and multiple-choice questions to enhance your clinical reasoning skills. A 6-month-old infant is brought to your clinic with poor feeding and excessive sweating. On physical examination, you note a harsh pansystolic murmur at the left lower sternal border. What is the most likely diagnosis? Your options are A. Ventricular septal defect, B. Atrial septal defect, C. Patent ductus arteriosus, or D. Tetralogy of Fallot. Think about the characteristic murmur location and quality, along with the associated symptoms suggesting heart failure in this infant. The correct answer is A. Ventricular septal defect. A VSD is characterized by an opening in the interventricular septum that allows blood to flow from the left ventricle to the right ventricle due to the pressure gradient. This creates a pansystolic murmur best heard at the left lower sternal border. The infant's symptoms of poor feeding and excessive sweating suggest heart failure from pulmonary overcirculation. In contrast, atrial septal defects typically produce a systolic ejection murmur at the upper left sternal border. Patent ductus arteriosus creates a continuous machinery murmur, and tetralogy of Fallot usually presents with cyanosis and a systolic ejection murmur, not the pansystolic murmur described in this case. Which of the following statements about the epidemiology of ventricular septal defects is correct? Your options are A. VSDs account for approximately 20% of all congenital heart defects. B. Most large muscular VSDs close spontaneously by age 5. C. VSDs are rarely associated with chromosomal abnormalities. Or D. The incidence of VSDs is approximately 1 per 10,000 live births. Consider what you know about the prevalence of this condition and its natural history. The correct answer is A. Ventricular septal defects account for approximately 20% of all congenital heart defects, making them the most common form of congenital heart disease. The incidence is 3 to 4 per 1,000 live births, which is much higher than the 1 per 10,000 suggested in option D. Regarding option B, it's actually small muscular VSDs, not large ones, that tend to close spontaneously. About 50 to 70% of small muscular defects will close on their own. Option C is incorrect because VSDs are frequently associated with chromosomal abnormalities, particularly Down syndrome, which accounts for 10 to 15% of cases. This association is important clinically because children with Down syndrome are more prone to developing pulmonary hypertension earlier. A 3-month-old infant is diagnosed with a VSD on echocardiogram. The cardiologist describes it as paramembranous. Where is this defect typically located? Your options are A. In the muscular portion of the interventricular septum. B. Near the membranous septum, below the aortic valve. C. In the inlet portion of the septum, adjacent to AV valves. Or D. In the outlet septum, just beneath the pulmonary valve. Think about the anatomical classification of VSDs and where the membranous portion of the interventricular septum is located. The correct answer is B. Paramembranous VSDs are located near the membranous septum, below the aortic valve. This is the most common type of VSD, accounting for approximately 60% of all cases. The membranous septum is a thin, fibrous portion of the interventricular septum located in the outflow region of the heart. The other types include muscular VSDs, which are located entirely within the muscular portion of the interventricular septum, outlet or supracrystal VSDs, which are located just beneath the pulmonary valve, and inlet VSDs, which are located in the inlet portion of the septum adjacent to the atrioventricular valves. Understanding the location is important as it influences the likelihood of spontaneous closure, potential complications, and the surgical approach if intervention is needed. A 4-month-old with a large VSD develops symptoms of heart failure. Which of the following best explains the pathophysiology behind these symptoms? Your options are A. Right to left shunting leading to systemic hypoxemia. B. Decreased cardiac output due to obstruction of right ventricular outflow. C. Left to right shunting causing pulmonary overcirculation. Or D. Ventricular arrhythmias from disruption of the conduction system. Consider the pressure differences between ventricles and how blood flows through a VSD. The correct answer is C. Left to right shunting causing pulmonary overcirculation. In a ventricular septal defect, blood flows from the left ventricle to the right ventricle due to the pressure gradient between these chambers. The left ventricle normally generates much higher pressures, around 80 to 100 millimeters of mercury, than the right ventricle, 25 to 30 millimeters of mercury. This left to right shunt creates excess blood flow to the lungs, leading to pulmonary overcirculation. The increased pulmonary blood flow returns to the left atrium and ventricle, creating volume overload. This volume overload causes the heart to work harder, leading to ventricular dilatation and eventually heart failure symptoms, including tachypnea, poor feeding, and failure to thrive. If left untreated, pulmonary vascular resistance can increase over time, eventually leading to pulmonary hypertension and potential shunt reversal. A 7-month-old infant is brought to your clinic with poor weight gained despite adequate caloric intake. On examination, you note a pansystolic murmur at the left lower sternal border and a hyperactive precordium. Which of the following clinical signs would most likely be present in this infant? Your options are A. Central cyanosis, B. Clubbing of fingers, C. Tachypnea with increased work of breathing, or D. Widely split second heart sound. Consider the pathophysiological consequences of a hemodynamically significant VSD and how they manifest clinically. The correct answer is C. Tachypnea with increased work of breathing. This infant presents with classic signs of a large, hemodynamically significant VSD, including poor weight gained despite adequate caloric intake, a pansystolic murmur, and a hyperactive precordium. The left to right shunting causes pulmonary overcirculation, leading to pulmonary congestion and increased work of breathing, which manifests as tachypnea. Central cyanosis is not typically seen in an uncomplicated VSD with a left to right shunt and would only develop if there were significant pulmonary hypertension leading to shunt reversal, which is unlikely at 7 months of age. Similarly, clubbing is a late finding associated with chronic hypoxemia and would not be expected at this age with a predominantly left to right shunt. A widely split second heart sound is characteristic of atrial septal defects, not ventricular septal defects. A 5-month-old with suspected VSD is being evaluated. Which diagnostic test is most useful for confirming the diagnosis and characterizing the size and location of the defect? Your options are A. Electrocardiogram or ECG, B. Chest X-ray or CXR, C. Echocardiogram, or D. Cardiac MRI. Consider which imaging or diagnostic modality provides the most detailed information about cardiac anatomy and blood flow in real time. The correct answer is C. Echocardiogram. Echocardiography is the gold standard for diagnosing ventricular septal defects. It provides detailed real-time visualization of cardiac anatomy and blood flow dynamics. With echocardiography, we can precisely determine the size, location, and number of defects, assess the direction and magnitude of shunting using color Doppler imaging, estimate pressure gradients across the defect, evaluate for signs of pulmonary hypertension, and identify any associated cardiac anomalies. While other imaging modalities provide useful information, they have significant limitations. An ECG might show ventricular hypertrophy in large VSDs but cannot confirm the diagnosis. Chest X-rays may demonstrate cardiomegaly and increased pulmonary vascularity in significant defects but lack specificity. A 6-month-old infant with a large VSD has poor weight gain, tachypnea, and is diagnosed with heart failure. Which of the following is the most appropriate initial management approach? Your options are A. Immediate surgical closure of the VSD, B. Medical management with diuretics, ACE inhibitors, and nutritional support, C. Pulmonary artery banding as the definitive treatment, or D. Observation and reassessment in 6 months. Consider the stepwise approach to managing heart failure in infants with large VSDs. The correct answer is B. Medical management with diuretics, ACE inhibitors, and nutritional support. For a 6-month-old with a large VSD and heart failure symptoms, the initial approach should be medical optimization before considering surgical intervention. Diuretics like furosemide help reduce pulmonary congestion by decreasing preload. ACE inhibitors such as captopril reduce afterload, improving cardiac output and decreasing the left to right shunt. Nutritional support with high-calorie formula helps address failure to thrive. While surgical closure will likely be needed, immediate surgery without medical stabilization isn't the first step. Option C, pulmonary artery banding, is reserved as a palliative procedure when complete repair isn't feasible, such as in infants too small for cardiopulmonary bypass or with multiple VSDs. Option D, observation for 6 months, would be inappropriate given the presence of heart failure symptoms. The infant should be closely monitored to assess response to medical therapy, with surgical intervention planned if medical management fails. A 9-month-old infant with a large VSD and heart failure symptoms is not improving with medical management. Which surgical approach is most commonly used for VSD closure? Your options are A. Patch closure via median sternotomy using cardiopulmonary bypass. B. Transcatheter device closure as primary approach. C. Pulmonary artery banding as definitive treatment. Or D. Primary suture closure via thoracotomy without bypass. Consider which approach provides the most reliable and complete closure for large VSDs. The correct answer is A. Patch closure via median sternotomy using cardiopulmonary bypass. This is the gold standard approach for surgical management of large VSDs, particularly in infants with heart failure symptoms that aren't responding to medical therapy. The procedure involves making an incision through the sternum, placing the patient on cardiopulmonary bypass, and typically approaching the defect through the right atrium and tricuspid valve. A synthetic patch, usually Dacron, or autologous pericardial patch, is then sutured over the defect to achieve complete closure. This approach has excellent outcomes with success rates exceeding 95% and mortality less than 1% in experienced centers. Transcatheter device closure, option B, is not generally used as the primary approach for large VSDs in young infants. It's typically reserved for specific types of defects, such as muscular VSDs or residual defects after surgery. Pulmonary artery banding, option C, is a palliative procedure, not a definitive treatment. It's used when complete repair isn't feasible. Primary suture closure without bypass, option D, would be technically challenging and risky for a large VSD. A 3-year-old child with an unrepaired large VSD has developed increasing cyanosis and decreased exercise tolerance. On cardiac catheterization, pulmonary vascular resistance is elevated. What serious complication has likely occurred? Your options are A. Infective endocarditis. B. Aortic valve prolapse. C. Complete heart block. Or D. Eisenmenger syndrome. Think about the natural progression of an unrepaired large VSD and what happens to pulmonary vascular resistance over time. The correct answer is D. Eisenmenger syndrome. This represents the end-stage complication of an unrepaired large VSD. Initially, a large VSD causes left-to-right shunting with pulmonary overcirculation. Over time, this excess pulmonary blood flow leads to reactive changes in the pulmonary vasculature, including medial hypertrophy and intimal proliferation. These changes cause progressive increases in pulmonary vascular resistance and pulmonary arterial pressure. Eventually, when pulmonary pressure exceeds systemic pressure, the shunt direction reverses to right to left, resulting in deoxygenated blood entering the systemic circulation. This shunt reversal manifests clinically as cyanosis and decreased exercise tolerance, which are the symptoms described in this 3-year-old child. The other options don't explain the combination of findings. Infective endocarditis would present with fever and new murmur, not increasing cyanosis. Aortic valve prolapse can occur with paramembranous VSDs but doesn't cause cyanosis. Complete heart block may cause exercise intolerance but doesn't explain cyanosis or elevated pulmonary vascular resistance. A newborn with Down syndrome is diagnosed with a large VSD. Compared to other infants with similar-sized VSDs, which of the following is true regarding this infant? Your options are A. Higher risk of early pulmonary vascular disease. B. Lower incidence of heart failure symptoms. C. Higher rate of spontaneous VSD closure. Or D. Reduced response to medical management. Think about the unique characteristics of cardiac disease in children with Down syndrome, particularly regarding pulmonary vascular reactivity. The correct answer is A. Higher risk of early pulmonary vascular disease. Children with Down syndrome have a unique pulmonary vascular biology that predisposes them to develop pulmonary hypertension earlier and more rapidly than other children with similar cardiac lesions. The pulmonary vasculature in Down syndrome is characterized by fewer alveoli and abnormal development of pulmonary arterioles with thinner medial walls. These anatomic differences, combined with other factors like increased risk of upper airway obstruction and frequent respiratory infections, accelerate the development of pulmonary vascular disease. Because of this increased risk, surgical repair of VSDs in children with Down syndrome is typically recommended earlier, by 3 to 4 months of age, compared to 4 to 6 months in other infants. The other options are incorrect. A 1-year-old child had successful surgical closure of a large VSD 6 months ago. What is the most accurate statement about long-term outcomes following VSD repair? Your options are A. Most children require lifelong anticoagulation therapy. B. Long-term survival approaches that of the general population when repair is performed early. C. Competitive sports are permanently contraindicated. Or D. Most patients develop arrhythmias by adolescence. Consider what we know about the prognosis after successful VSD repair in the current era. The correct answer is B. Long-term survival approaches that of the general population when repair is performed early. Studies consistently show excellent long-term outcomes after successful VSD repair, with survival rates exceeding 95% at 20 years. When repair is performed before the development of pulmonary vascular disease, most patients can expect a normal life expectancy and quality of life. The other options contain common misconceptions. Anticoagulation therapy is not routinely required after VSD repair unless there are other indications, such as a mechanical valve or arrhythmia. Most patients can participate in all physical activities, including competitive sports, after complete healing from surgery, typically 3 to 6 months post-repair. While some patients may develop arrhythmias, particularly after complex repairs or if surgery was performed later in the era before modern surgical techniques, it's incorrect that most patients develop arrhythmias by adolescence. The incidence is much lower, with less than 10% developing significant arrhythmias by adulthood after isolated VSD repair. You're educating parents of an infant with a newly diagnosed moderate VSD. Which of the following should be included in your family education? Your options are A. Strict bed rest is necessary to prevent heart failure. B. A low-sodium, low-fat diet should be followed indefinitely. C. Signs of increased work of breathing require prompt medical attention. Or D. Vaccination should be avoided due to cardiac strain. Consider which guidance would be most appropriate and evidence-based for families managing a child with a moderate VSD. The correct answer is C. Signs of increased work of breathing require prompt medical attention. Parents should be educated to recognize warning signs of heart failure or worsening hemodynamic status, with increased respiratory effort being one of the most important and reliable indicators. Increased work of breathing manifests as nasal flaring, subcostal or intercostal retractions, grunting, or tachypnea, and signals that the child may be developing pulmonary congestion from the VSD. The other options contain incorrect information. Strict bed rest is not necessary for children with VSDs and could actually impair normal development. Children should be allowed normal activity levels as tolerated. A low-sodium, low-fat diet is not routinely recommended for children with VSDs. While some sodium restriction might be temporarily advised in severe heart failure, indefinite dietary restrictions are unnecessary and could interfere with normal growth. A 5-month-old with a large VSD is admitted with heart failure symptoms. Which nursing intervention is most important for this patient? Your options are A. Restricting all oral intake and providing total parenteral nutrition. B. Monitoring respiratory status and work of breathing. C. Limiting handling and stimulation to reduce oxygen consumption. Or D. Administering supplemental oxygen at all times. Consider which nursing intervention addresses the most critical physiologic concerns in an infant with heart failure due to a large VSD. The correct answer is B. Monitoring respiratory status and work of breathing. In infants with large VSDs and heart failure, respiratory compromise from pulmonary overcirculation is the most critical physiologic concern. Careful and frequent assessment of respiratory status, including rate, effort, presence of retractions, nasal flaring, or grunting, provides essential information about the infant's clinical status. These assessments help evaluate response to treatment, detect early deterioration, and guide medication adjustments. Option A, restricting all oral intake and providing total parenteral nutrition, is excessive and rarely indicated. While some feeding modifications might be necessary, such as smaller, more frequent feedings or higher calorie formulas, complete restriction of oral intake is not a standard approach and could impair growth and development. Which of the following represents the most significant recent advancement in the management of muscular VSDs? Your options are A. Development of new diuretic medications. B. Transcatheter device closure techniques. C. Gene therapy to promote spontaneous closure. Or D. Artificial intelligence-guided surgical planning. Consider the technological innovations that have changed how we approach certain types of VSDs in recent years. The correct answer is B. Transcatheter device closure techniques. This represents one of the most significant advances in the management of muscular ventricular septal defects in recent years. Traditionally, all VSDs requiring intervention were treated with open-heart surgery. However, transcatheter approaches now allow certain types of VSDs, particularly muscular defects, to be closed using catheter-delivered devices without requiring cardiopulmonary bypass or sternotomy. These procedures typically involve accessing the heart through blood vessels in the groin, navigating to the defect, and deploying a double-disc occluder device that sandwiches the ventricular septum. The main advantages include shorter hospital stays, faster recovery, reduced procedural morbidity, and no surgical scar. Currently, muscular VSDs, post-surgical residual VSDs, and some apical defects that are difficult to access surgically are the best candidates for this approach. The other options don't represent current significant advances in VSD management. While diuretics remain important in medical management, there haven't been revolutionary new diuretic medications specifically for VSD management. Gene therapy to promote spontaneous VSD closure remains theoretical, not a clinical reality. And while AI might enhance imaging or surgical planning, it hasn't yet revolutionized VSD management to the degree that transcatheter techniques have. Thank you for joining our comprehensive review of ventricular septal defects in pediatrics. Let's summarize our key takeaways. First, understanding the pathophysiology of VSDs is essential. The left-to-right shunting creates pulmonary overcirculation leading to potential heart failure and, if left untreated, pulmonary vascular disease. Second, management must be individualized based on defect size, location, symptoms, and patient factors like the presence of Down syndrome. Options range from observation for small defects to medical management and surgical or transcatheter intervention for larger ones. Third, with appropriate and timely intervention, the prognosis for children with VSDs is excellent, with survival rates approaching those of the general population. I encourage you to subscribe to the Pediatric Case Review channel for more educational content on pediatric cardiac conditions and other pediatric topics. If you have any questions about ventricular septal defects or suggestions for future presentations, please leave them in the comments section below. This is Dr. Abdelaziz Yousef, thanking you for your attention.